Today we're speaking with my dear friend, Dr. Chelsea Stone. I have had the pleasure of working with Chelsea when she was a neurology resident at Loma in the University Health. So we've had a lot of conversations, and Chelsea was the kind of resident when she would be on, and whenever an attending would be on, they would look at the list and see which resident is on. And if Chelsea was on, we would know that it would be a good night. We would know that every patient would be taken care of. We would know that we would not get any, strange calls or anything of that nature. We didn't have to worry. And there was a sense of comfort and confidence that came with Chelsea.
Yeah.
And I've always admired her. And Chelsea, I am so grateful to you that you took this time to come and speak with us about a topic that you are an expert in, and you've always been very passionate about, which is headaches.
I mean, just to expand on that a little bit, I worked with you, and I second that thought process that Aisha was saying, that sense of confidence. All your children might be equal. I know you have a child now, and you have hopefully others, and maybe, and you'll feel that they're equal, but residents are a little different as far as confidence is concerned. When you're on call, when I was on call with Chelsea, it was not without question. I would actually say that she knows more than me about headaches.
Oh yeah.
And more important than that, data is easy. In the age of AI and connectivity, we will all have data, but passion for a topic is critical, because the passion opens up both creativity and also a realm of knowledge acquisition. So a lot of things we want to say about you, about the experience we had with you, but more importantly, now you're an amazing attending at USC, doing amazing work in this very, very important field. So we're so glad to have this conversation with you.
It's an honor to be here. This is really exciting for me.
So Chelsea, tell us about your work at USC.
Yeah, so I am a headache specialist. So I'm working with fellows, but also working with residents, teaching them about headache. And we get a variety of really complex headache patients at USC. I mean, sometimes they just don't even fit a particular category. And so I also do some work at the county, working with residents as an attending on general neurology. But really, the vast majority of what I do is work with headache patients.
Amazing. And it's wonderful that you're working at a university-based hospital system, because one of the things that Dean and I always tell patients is, try to go to a university-based hospital system for your care, because they always have that comprehensive care system where, say, for example, if somebody goes there for neuromuscular problems, you don't just see a neurologist. You see a super specialist in that field. You also have access to PT or physical therapy, occupational therapy, to psychologists, to other, ancillary groups that can enhance your experience and can help you as well. But I love the fact that you work in the county too, because correct me if I'm wrong, the people that come to the hospital and the people who are actually in the county and not necessarily have access to come to the hospital are very different, aren't they?
They're very different. So when I see patients at USC, most of those patients, although we do see some patients with not very good insurance, but we only get to see them one time. And that's really, it's hard for me because I want to see them all the way through, right? And so the patients we see at Keck, we can get them involved in our multidisciplinary program very easily. We get them in with OT, PT, pain psychology, everything that you just brought up. But when we see patients at the county level, it's really hard to get them those resources, right? And so one of the things I'm doing at the county level is we're actually doing headache groups to try and give some of the education that patients will get at Keck or other hospital-based systems, resources like physical therapy, occupational therapy, just giving them some of those tools that they may have not otherwise been able to receive, just because of the sheer volume of patients at a county level.
Yeah.
Something that I want to, and I always am interested in this, is what makes people go in a given direction. And sometimes it's just life experiences, just accidental. We stumble into something, but from the experience we had, as far as your passion for this field, I'm sure that there's another story to this. What brought you to this field? First neurology, and then to headache as a specialty.
Sure. So that's truthfully a very difficult question for somebody like me because I'm very indecisive and I like a lot of different things. And so actually, when I was choosing a specialty, I really struggled. I went all over the map. I really enjoyed every single one of my rotations in medical school, every single one. And I could see myself in every single one. So truthfully, I actually applied to 2 different specialties and just thought, okay, whatever happens, happens. Yeah. And so one of them was neurology and one was internal medicine. Mm-hmm. And I'm so grateful that I ended up in neurology. It's such a good fit for me. I have a background in psychology, both a bachelor's degree and a master's degree. And I found that served me really well in neurology. I have a passion on that mind-body connection. And it served me really well as a headache specialist too, because there is so much of a comorbid, a high rate of comorbidity with depression, anxiety, and other, mental health issues with migraine.
Yeah.
And I thought it's really served me well.
Yeah. I've always found, as a neurology resident, I always found headaches a bit intimidating. Intimidating in ways where, you're dealing with a person who is just suffering tremendously. I mean, of course, most of these diseases are pretty bad, but having pain, and dealing with pain day in and day out just completely changes your life and completely changes your perspective about yourself and about the world. And so I always took it very seriously, but I also have tremendous respect for people who deal with pain conditions on a day-to-day basis. It can be really hard.
When we first married, Aisha and I still had some remnants of migraines, and I've suffered from migraines most of my life. I have a family history of migraines. My uncles were both surgeons, had severe migraines, and I had migraines, and it was so bad that, and the moment I would feel the predor, the headache coming, it was a frightening experience because I knew what was about to come, and I had to do whatever I could to stop it. But most of the time, I wouldn't be able to, and I would have that migraine at least once a week, if not more. It was so debilitating that at the tail end of it, when I first got married with Aisha, there was one occasion when we were actually in this train station in DC, and the headaches came on, and they came on rapidly. The migraine, the one side of the head, I started feeling these lights coming, the scintillating lights, and I felt the nausea. I felt the light hurting me, the sound, photophobia, so on, so forth. And then all of a sudden, I was so debilitated that in the middle of this huge crowd, and she was like, wait a second, I'm married this dysfunctional person. No, I was on the ground.
Bad.
I was on the ground, and I didn't care who was around me or what was around me. Mine, thankfully, for the last 16 years now, I've had no migraines. It happened at the same time that I changed my lifestyle, diet. I had a terrible diet, let's just say that. And I went plant-based, but I never bring it up as a case because I hate when people bring anecdotes as a case because one case doesn't mean it, even if it's your own, even if you have a direct relationship, they're still not enough of a case to make. Yeah. But for me, I remembered that dread. And I respect people that are going through it, but even more people that are taking their time to treat people with migraines and other types of headaches. So I definitely respect what you do, and from a personal perspective, and there's a historical perspective in this. Mary, Queen of Scots. Do you know about that story?
No.
I don't know if it's true or not. I'm probably going to get letters from Scotland or from family of Queen Mary. That she had severe migraines, and whenever she had it, it was a bad day for the kingdom. What? Let's just say that. You can look it up. But nonetheless, it's a difficult situation to be in, be it migraines and other kind of headaches. So having said that, I just wanted to kind of give you a little perspective of what I've gone through and now where I am. When you are dealing with headaches, when somebody comes in with a headache, I would love for the general public to get an idea of how you think I'm going to approach this headache. What are the questions so they can start becoming more aware of it?
Absolutely, absolutely. And thank you so much for sharing your story. I don't usually hear people that get 15 or 16 years of headache relief. That's great.
Yeah.
So when I hear a patient, the first thing I want to know is, how many headache days are you having in a month, right? Because that helps me identify, is this somebody that's having, episodic headaches or chronic headaches? Anybody that has 15 headache days or more a month, it's chronic. And then I also want to know, have you had a period of time where you had fewer headache days? Is there a seasonal component? Because that leads us one direction. Is there a positional component? And then I also want to know, am I hearing any red flags, right? So first things first, is this your first headache of life? Or have you been having headaches for a long period of time? So the first thing I ask patients is, when was the first time you had a headache? And probably 50%, and at least the data supports this as well, have had their first, in terms of migraine, before age 12. So a lot of my patients are like, I don't remember even not having headaches. I've had them forever. And many of them are trying to find what caused that to happen, right? Like, is there something they did? And so we go a little deeper and do you have family members with headaches? And then has anything made it better? Anything made it worse? Do you feel like you have any triggers? And by the time people come to me, being an academic center, they've usually tried a variety of different things. They've seen other neurologists. They have head imaging. And many of them come in with the impression that maybe they just have what we call tension headaches. And later we realize that no, in fact, you have migraine or probable migraine, or you have some of these other headache disorders. So these are the things that I kind of start a visit with. There's just so much to find out about a particular patient, and everybody has such an interesting story.
Yeah.
And it really takes at least a good hour to get to know a story and understand what kind of headache type they have and how can we best go about treating it.
I love the fact that so much of our diagnosis in neurology comes from conversations and just, a good history. And I remember Chelsea, just being your attending and us being in neurology grand rounds, it's that history that matters the most, and finding life patterns and symptom patterns that tells us quite a lot. I'm going to get a little specific now. So the words headache and migraine are used interchangeably, right? It's very common for people to say, oh, I have a migraine. And then when we see them in the neurology clinic, it's not necessarily a migraine. It's a different type of a headache. Could you give us the difference between the two, or maybe just kind of give us like an idea of how headaches are all classified?
Absolutely. So I think this is a really good question and really important question, because oftentimes we'll ask, somebody will tell like a coworker that they are having a migraine. And sometimes a coworker will say something like, that's okay, I get headaches too. And that's really hard for a migrainer to hear, because it's not just a headache. Just as Dean was mentioning earlier, it's so much more than that. There is the premonitory symptoms that can last from hours to days prior to the actual headache onset. For about 30% of migraineurs, they can have an aura, just as you were describing, this scintillating scotomata. I always have a hard time pronouncing it. You can see flashing lights. 90% of the time they're visual. And then you get the headache part. And this is often after, a couple days of having other symptoms like cognitive fatigue, cognitive clouding, word finding difficulty. There's a lot of yawning, increased urination. People, as I mentioned, fatigue. There's just a nausea. People will have maybe some appetite changes.
Yeah, a lot of GI changes too, right? Sometimes people actually get diarrhea for some reason.
Yeah. Some people have diarrhea. A lot of my patients, and we hear this, have migraine-induced gastroparesis, so they actually have a slowing down of their GI tract. There's just a variety of different symptoms that go with migraine that are so much more than just the headache itself. And for some people, it's actually more debilitating than the actual headache. And 80% of migraineurs will have that premonitory or prodrome prior to the onset of the headache. And then the headache itself will last, 4 to 72 hours if untreated. Can even go longer, and something called status migrainosis, which means that it lasts over 72 hours. And then after that, you can have a postdrome where you feel tired after having this debilitating headache lasting 24 hours. It's just a very long process. And then in between these events, we have the interictal phase. So migraine is a syndrome. It's not just a headache.
Yeah. Wow. Yeah. That's amazing. And it's important for people to know that. And of course, it's important for people to see a neurologist and a specialist to help them differentiate between these, because the treatments are very different, aren't they?
Very different. Very different. Absolutely. Headaches, just a general headache is often responsive to maybe NSAIDs, just over-the-counter medications. But people with migraine, sometimes they're lucky and their headaches will respond to NSAIDs. And by NSAIDs, I mean like non-steroidal anti-inflammatory medications, like ibuprofen or naproxen, or even acetaminophen for some people. But when you have a migraine, it can oftentimes require more than that. That being said, some people with migraine also just have basic headaches. That's part of the criteria for migraine is you just have to have, for example, for chronic migraine, you have to have 15 headache days or more a month, only 8 of which need to be classified as migraine. And so the diagnostic criteria for migraine is that, it's often unilateral, throbbing, made worse by physical activity. That's the pain component. And then there's associated symptoms, just kind of what we were discussing earlier, sensitivity to light, sensitivity to sound, nausea, or vomiting. And you have to have either sensitivity to light and sound, or you could just have nausea, and that's when it's migrainous.
Well, and so it's very common. It's common for people to have migraines as well as other types of headaches, right?
Absolutely.
Yeah. Before we go any further, you brought up this concept of first-time headache versus a chronic headache. And about 3% of population of the world have chronic headaches, but 50% have headaches in general, from the latest WHO findings. But what's important is this primary versus secondary, or a new headache. I'm kind of mixing up these concepts a little bit, but your point is extremely important for people to know that sometimes when you're having a headache for the first time, it could be something very important that you really need to get it checked out, because it could be, and we'll get into what this could be, but it could be telling of something much worse. So if you are, in your 30s, 40s, and for the first time you're having a severe headache, that's a completely different thing that must, put up the red flags and get you moving to see a doctor as soon as possible, because that's a completely different phenomenon. Having said that, what kind of statistics do we have around headaches? I mean, we know that it's one of the most common things that brings people to the emergency room, but can you give us some numbers?
Sure. So at least 1 billion people in the world suffer from migraine. 1.89 billion suffer from tension-type headache. 39 million in the US. And so 1 in 4 households is affected by migraine. Each year, there's 3.5 million visits to the ER for headache, most of which are due to primary headache types like this migraine, trigeminal autonomic cephalalgias, which we haven't touched upon yet, or tension type headaches. There's $20 billion spent on headaches every year in the US. That includes obviously people that are disabled, loss of revenue. And then those are the statistics I can think of offhand.
Mind-blowing.
Yeah, mind-blowing, absolutely. I mean, if we could even bring a small dent into this massive problem for society, it would be so amazing, so remarkable. And we'll get into that as far as detecting it earlier, understanding it earlier, treating it earlier. All of these things are possibilities going forward. But so as far as differences, genders, as far as sex differences, cultural differences, age differences, what do we know about that?
Yeah, so basically before puberty, boys and girls are affected differently. And then once puberty happens, girls just, female gender really takes off. And so about 18% of females are affected with migraine, whereas about 7-8% of men.
No.
Yeah. So it's like a 3-to-1, about a 3-to-1 ratio.
And do we know why? Is it a hormonal variable? Is it what are the variables that usually contribute to these different the difference?
We do think that it is because of, we know that estrogen in the menstrual cycle is a trigger. So we do think that the hormonal fluctuations play a big role. Estrogen affects a number of different mechanisms with migraine. So we found that there is an estrogen withdrawal hypothesis, which shows that, in the late luteal phase, early follicular phase of the menstrual cycle, estrogen and progesterone drop. And that's when a number of my patients all of a sudden get their migraine. In fact, menstrual migraine is one of the types that we see. So it starts a couple days before the menses, and then about 3 days into menstruation. Your body, migrainous brain doesn't like to be fluctuating. It likes to be constant.
Homeostasis. That's intriguing because so now that brings on the pregnancy question. We just did a session on multiple sclerosis and some of the autoimmune diseases. And during pregnancy, things change. There's a ebbing of the phenomenon of the inflammatory process. You just had a pregnancy, about a year ago or so. And so what happens during pregnancy to a headache? Specifically in this case, we're talking about migraines, right?
Right.
What happens to migraines during pregnancy? It just kind of intrigued me about that question.
This is one of my favorite topics in headache. Actually, in fact, whenever there's a pregnant patient or a woman that wants to get pregnant or is postpartum, I ask the rest of the group to send them my way. This is my favorite group of patients to treat. So during pregnancy, during the first trimester, there can be an uptick in headaches, right? As your hormones are changing rapidly. And then once you hit the second and third trimester, we actually see improvement as the estrogen and progesterone level off. And so about 85% of women by the third trimester, those with migraine are doing much better. But we do see some other things with pregnancy. You are gaining weight rapidly, right? So there are some other conditions you're at increased risk for, like idiopathic intracranial hypertension, because you do so. And there's some other things too that you need to consider. We were talking about secondary types of headache earlier, and pregnancy is one of those things that you need to consider. If somebody has a change in headache type, new onset headache during pregnancy, those patients really need to be imaged, right? Because you are at increased risk, given that you're hypercoagulable when you're pregnant, for things like venous sinus thrombosis, blood clot in the venous system, or strokes. These are things you really need to look into if you're pregnant.
One statement that you said was most people start having headaches before the age of 12. So children do have headaches as well. Can you talk about that, like children having headaches and how that should be dealt with, and whether those are migraines and it's something that's not as dangerous or as ominous as the headaches in adults are concerned? How do you deal with that?
That's a big question, and it's a very important question. So headaches in children are different than adults, but in some ways they're the same. So headaches in children, they often experience premonitory symptoms. They'll have the yawning, they'll have increased urination, they'll have fatigue. Sometimes and they'll also have that postdrome that we discussed. But migraine in children is often shorter. Theirs usually lasts about 2 hours, and more often their headaches are bilateral. as compared to adults.
Okay. Their migraines are bilateral.
Their migraines are often bilateral.
Okay.
Absolutely.
I mean, just to kind of expand on that, initially, migraine, and you can correct me on this, but the general concept was that it was unilateral, or it's called hemicrania, one-sided. But we know that about 45 to 50% are not one-sided, right?
That's right. It's in the classification, but many of my patients report bilateral. But with children, that's just generally speaking, we know that they report that it's bilateral, but in reality, we see that headaches in adults are often bilateral as well.
Yeah. Sorry, go ahead. No, speaking of children, one thing should be in our list of things to worry about is if it's a new headache and it's pretty bad, because children also have these, they can have brain occupying tumors, especially in the posterior fossa in the back of the head. If there's altered mental state, if they're having difficulty walking, dizziness, spinning sensation, any of those symptoms, anything, there should be a lower threshold of getting it checked because of those factors.
Absolutely. And, I think that we need to take headaches in children seriously. I think sometimes people assume, they're just trying to get out of something. And that's really not, are they trying to get out of school, trying to go home? That's not really the case. You really need to take these things seriously. And just as you said, if they're reporting, pain in the back of the head, or they having other focal neurological signs, it needs to be taken seriously. Absolutely.
I think this is a good transition point to kind of give our audience a general idea of the major types of headaches. So if you could just kind of classify for everyone, what kind of headaches are there?
Absolutely. So there are a lot of different kinds of headaches. But the way I think about it is there's primary headaches, and that's headaches like migraine that we keep bringing up. This other class of headaches called trigeminal autonomic cephalalgias. Trigeminal meaning, the trigeminal nerve, and it's often involving the ophthalmic branch and the V1 distribution. So near the eye, temporal region. And then autonomic, there's a variety of autonomic features where patients will have, on the same side of their pain, they will have things like tearing, their nose will run, they'll have facial flushing, eyelid edema, swelling of the eyelid, their pupils will get smaller on that same side, drooping of the eyelid, their ear will feel full. And sometimes with headaches such as cluster headache, which is a type of trigeminal autonomic cephalalgia, they will feel restless and agitated, which is different than migraine, where often you feel fatigued.
Yeah.
And cephalalgia means headache, pain in the head. So that's another category of headaches, and there's several different kinds broken down there. But for brevity, I won't go into that too much right now, unless you want me to, which I'm happy to.
Those are like the board questions. If it's the last 2 minutes, you do and they respond to the medicine. Yeah, exactly.
Yes. And two of the trigeminal autonomic cephalalgias are, how do they put it? Absolutely responsive to indomethacin. That's right. That is a board question. And the other kind would be tension type headache, which we don't often see in our clinic. Those are the three big categories. And then there's other primary types of headaches like hypnic headache or nummular headache, which means coin-shaped, primary stabbing headache. These are all primary type of headaches that we know about. And then there's secondary headaches, which we've talked about a little bit. One headache type that I really like to bring up is one called medication overuse headache. This one doesn't require, being taken to the ER. It's not something that requires urgent imaging, but something I hear about often in clinic is that patients are taking what is called acute or abortive medications too much, right? Mm-hmm. So they're taking ibuprofen every day, Tylenol, opioids, or, there's a class of medications for migraine called triptans. Uh-huh. Some of the patients will get upset that they only get 9 tablets a month. but that's because there's a high rate of medication overuse with something like triptans. Butalbital, which is Fioricet is another name for it. That is one secondary cause of headache, and we see it all the time with migraine, and it makes it very difficult to treat migraine, actually. There's some other types of, I listened to your podcast on traumatic brain injury, and I see so many patients with post-traumatic headache that actually look like migraine, but it was the result of TBI, right, of traumatic brain injury. I see that all the time in my clinic. And then other types of secondary headaches that we need to look into, there's a mnemonic called SNOOP, where we look, are there systemic signs? Does the patient have fever? Because then we need to be concerned. Do they have meningitis? Do they have, some other cause for their symptoms? Look at, are they having neurological symptoms? Is there weakness on one side? Are they having papilledema or on physical exam or vision changes that aren't or more of what we would call negative symptoms where there's a loss of vision?
Yeah.
It's something to look into. What is the onset? So what we call thunderclap. So if somebody can clap their hands and all of a sudden it just goes from 0 to 10, that needs urgent imaging, right? Because that's concerning for a bleed or a stroke, or there's some other conditions that, like reversible cerebral vasoconstriction syndrome that can cause thunderclap headache. Older age, if somebody just started getting headaches and they're over age 50, that's a reason that you need to go seek care. There should be some imaging done. And then you get to the P's, right? And we've already discussed pregnancy and postpartum, where somebody, we really need to consider an MRI. A positional component. So does the headache get worse with bending over, with lying down? This could mean that there is something related to cerebrospinal fluid, like too much pressure, too low pressure. Requires further investigation. Is it precipitated by Valsalva? So like if somebody's straining, bending over, coughing, sneezing,
or bowel movements. Yeah.
Bowel movements, exactly, defecation. Then that's another could make us concerned for a secondary headache. I think I hit them all. Not sure. A lot of them. There's a lot.
Thank you.
There's a lot.
Thank you.
No, but
You're right.
that's critical because for people to understand that these are all important things. And the first thing to distinguish are the urgent things. When it's the worst headache of your life, or when you describe this thunderclap, we talk about bleeds, aneurysms, significant trauma to the vasculature of the brain or meningi that can bring this on. And those are the things that should be addressed immediately in the emergency room.
Right.
Immediately.
And then everybody knows everybody's heard about migraines, but they haven't heard about all these other things. For example, one of the things that you talked about, which is the cluster headaches, which are significantly more common in men than women, right?
Yes.
Yeah, about 40 times more common. And the quality is very different.
Very different.
Whereas in migraines, this throbbing, heavy feeling in the head or one side. With the cluster, it's almost like knife-like, like as somebody's with hitting back of your eye with a pick fork or something of that nature, right?
Yes, and I've seen patients in my clinic having cluster headache, and it is very different in appearance. I mean, some people will actually hit their head because it feels better, and they're just so restless and agitated. As compared to somebody with migraine where they just want to lay down and feel better. And another name for cluster headache is actually suicide headache, because there are people that have had so much pain. I mean, it's 10 out of 10 pain. There are, we always talk about this as a way to understand the quality of a cluster headache is there are 3 things that can cause 10 out of 10 pain. I'm sure there are more than that. But childbirth, a kidney stone, and cluster headache. And so it is just a very different, it is associated with often it's a young man that's smoking or drank the night before, and then they come to the ER with this 10 out of 10 headache. What's interesting about it, as you know, is that the best treatment for it is actually pure oxygen.
It's fascinating how different they are and how important it is for people to know that the treatments are also very, very different. You expanded a little bit on that important category. I don't know if it is a category, but a different variation of headache, which is medication overuse. And we see that quite often in clinic. And as you mentioned, medication overuse is essentially seen in people who take way too many over-the-counter medication and also some triptans. And so taking too many medication causes more headaches, right? I mean, it doesn't make any sense when you look at it, as a layperson, like, how is it possible for me to have more headaches if I'm taking more pain medication? How does that happen? Right.
That's a big question. And actually, I don't entirely understand the pathophysiology behind it. I do know that it makes it harder to treat headaches with preventative therapy. Interestingly. So, I think this is kind of a good segue into preventative versus abortive headache therapy,
absolutely.
if you don't mind. So if you're having more than 4 headache days per month or migraine per month, I digress, just headaches per month, or you're having headaches that are very debilitating, even twice a month, then you probably should be on a preventative medication. And those are not treatments that are going to give you medication overuse. Again, like as you're saying here, that it's really the acute medications, like these over-the-counter medications, triptans, opioids, Fioricet is actually or butalbital is notorious for it. What we do see, is that sometimes if you're taking a medication every day, like ibuprofen or Fioricet, then when you stop taking it, you almost get like a withdrawal.
Yeah.
Right. So it's a medication withdrawal. It's just like we know about caffeine withdrawal. It's the same things. You take it every day, and then when you stop taking it, you get a headache.
Yeah.
And with these withdrawals or these overuse phenomena, it's almost like a baseline reset. It's a baseline reset phenomenon that the threshold is lower. So it takes much less to create that phenomenon. And it has to do mostly with the receptors. I mean, now we know that, I'm going to get into that a little bit with the migraines. We have many different kinds of migraines, right? So we learned so much. I always get irked. Maybe I'm a little defensive as a neurologist when they say, "Oh, we don't know." I mean, it is unbelievable.
Well, the statement that we don't know much about.
Yeah, it's like a not sequitur. It's just just to stop the conversation. They say, "Oh, but we don't know much about the brain." Well, we know a lot more than you think we know about the brain. And as far as, let's just take one thing, as far as migraine is concerned, we know quite a bit as far as mechanistics, as far as, these channels and abnormal channels that are the causative, and even the genetic patterns behind those channels and channelopathies, let's say, that we've learned quite a bit about, haven't we?
Yes. So I feel, are you talking now about hemiplegic migraine when you're talking about channelopathies?
Yes, I'm going. This is my excitement about the field. You know what? I should get a little discombobulate with me jumping about, but I get excited because I remember Chelsea. One of the things I remember about Chelsea is occipital headaches. And she was ready with those injections. I
still love doing them.
I know. I never got to be very good at it, but it's mechanistic. This is what we're talking about, is understanding if something needs to be treated a priori so that we can lower it or raise the threshold so that it's less likely to happen, and others that are abortive that we can stop. And we've learned so much about both of those. And the importance of this is that for people who have headaches, they don't have to live with it. If one doctor doesn't know what to do with it, and usually generalists or primary care physicians, they might not know. And this is not a negative statement about that, because the knowledge has grown so much. Go to specialists like Chelsea and USC and other places that know so much about both abortive and preventative and phenomenon.
Yeah.
So I would love to hear a little more about that prodrome. That you said that people who have more than 2 severe headaches a month or 4 a month, that they should be on a medication, right?
Yeah. So when I said 2, I'm thinking of really severe, debilitating, like hemiplegic migraine.
Yeah.
People with hemiplegic migraine should be on a preventative. That is so hemiplegic migraine, for those who don't know, is where you basically look like you have a stroke. Yeah. You have significant weakness from your migraine, and it does run in families. There's a very strong genetic component. And yes, it is a channelopathy. There are 3 known ions that are involved. There's the CACNA1A, which is the familial hemiplegic migraine 1, and then there's ATP1A2, and then there's another one. There's a sodium channel, SCN, and they found that people with familial hemiplegic migraine, when they do the genetic testing, that they do have, one of these ionopathies. And so those patients really should be on a preventative therapy.
Right.
Yeah.
It's so wonderful that, like Dean was saying earlier, we now know the different mechanism of actions and what happens. And I'm so glad that the newer treatments that are coming out are very, very specific, right? I mean, they're actually medications that attack or focus on a particular ion or a channel or a mechanism, or nerve, and depending on what kind of treatments people get, they actually get a lot of relief from their conditions too. Coming back to the concept of the 2 types of therapies, abortive therapy and preventive therapy. People tend to get very concerned about being on a medication on a daily basis. And Chelsea, you know this very well. And the kind of conversations we have with people who need preventive therapy is very different from, here's a couple of Furosets and I'll see you in a couple of weeks, right? They'll just take the medication, and when they feel better, they're like, oh, it's gone, but then it comes back, right? So preventive is very important, but people are very scared of taking medications. What has your experience been?
So there's a couple of different things there. So one is that some prevention can be done with a couple of different vitamins, right? So there is magnesium that we found to be really helpful in prevention, and riboflavin, which is vitamin B2, we found to be helpful for prevention. And I found that people that are hesitant to take a daily medication, I can get them to start there, right? I can get them to start with with some supplements, right? And we do actually have some pretty decent evidence for both magnesium and for riboflavin. What level B was level B evidence. Unfortunately, they're supplements, so they're not regulated, by the FDA, unfortunately. But a lot of people are hesitant to take oral medications for headaches. And that is because there are some new medications that are specifically made for migraine. But the other medications that most insurance companies require you take before you can take some of these newer medications are not really migraine specific. They're things like beta blockers, right? Which can make you fatigue, can slow your heart rate. For some people with asthma, that's scary for them. And then also there's anti-epileptic medications. So you have, topiramate, which can cause word finding difficulty. So that's very scary. My college students, my medical students are always scared to take topiramate. There's other anti-epileptics that we found to be useful, like one called zonisamide, which is related to topiramate, we found to be helpful with less side effects. We found things like lamotrigine that occasionally can be helpful, not as strong as topiramate or zonisamide. And then a medication that we prescribe for migraine often is in the tricyclic antidepressant category. And so you hear some patients say things like, I'm not depressed, and why are you giving me this medication? And so the reality is that people don't really prescribe that medication as much for psychological reasons anymore. They often prescribe it for pain control and for insomnia, which is often concurrent with migraine. So those are some options, right? But people are really scared of these medications because they have a lot of side effects. Or they have the potential for a lot of side effects. So one thing I do, and for people that are listening that do treat headache patients, is I start very low and go slow. I start people at a pediatric dose. So I'm going to start you on nortriptyline or amitriptyline. Let's start at 10. Oh, you're not comfortable with that? Let's start at 5. And let's go really slow and just see how you tolerate it. If you don't tolerate it, let's stop. It's all about meeting the patient at a level where they feel comfortable, right? And then also integrating other forms of prevention that aren't medicinal, right? You can do things like, I am a big fan of getting people in occupational therapy. We have an excellent program at Keck where we do lifestyle redesign, getting people into physical therapy. TMJ is often a comorbid condition, having people work on learning how to relax their jaw. As you know, there's the trigeminocervical complex that's involved in migraine, getting people to learn how to strengthen different parts of their neck and not using their traps as much can be really helpful. I'm just a big fan of trying to integrate other modalities that are non-medicinal, particularly for my patients, or for all of my patients really, but for those patients that are hesitant to take a daily medication, I think we need to consider other options and really meet patients where they're at.
That's fascinating. And it's so awesome to hear that, because usually it's brushed off and kind of ignored. I mean, of course, we try to be evidence-based, but I think you have to look at the totality of what people can do. And I'm really happy that you actually touched on that. Some of the other comorbid conditions that also exist in people with headaches need to be addressed as well. And I know that, we're going to talk about that, but think like people living with sleep apnea, if they have sleep apnea and if they don't do anything about it, forget about your headaches getting better. I mean, that's such a huge reason why people have headaches, isn't that right?
Absolutely. Absolutely. So if somebody tells me, you were asking earlier about, what are some things you ask somebody when you're meeting them for the first time, getting a headache history, is, do you snore?
Yeah.
Do you snore? Do you wake up? Are you tired during the day? I mean, that can be helpful or it cannot be helpful. But are you waking up with a headache? And is it getting better as the day goes on? That's a sign that sleep apnea is probably contributing.
Yeah.
Absolutely.
Amazing. And in general, speaking about sleep, I mean, you and I were talking about sleep with Neuro Academy yesterday. Just having a good night's sleep or implementing sleep hygiene can also help with managing headaches, especially in people who have sensitivity to a particular type of lifestyle factor. So talking about lifestyle factors, or triggers, in your experience as a headache specialist, what are some of the most common triggers for migraines in people?
So this is a good question, and it's also a complicated question, believe it or not. So I've always heard things like chocolate's a trigger, right? Or, you hear that. It's chocolate's a trigger for me. Or you do hear some other things like sleep's a trigger, poor sleep is a trigger for me, stress is a trigger for me, the weather changing. So, or flashing lights, using the computer. So where it gets difficult is that some things that we think are triggers are not actually triggers, but that we're already in that premonitory or prodromal phase and we're more sensitive, right? So migraine is also sensory disturbances. We're more sensitive to things, right? So as it turns out, chocolate is probably not a trigger. It's more likely that we're craving different foods when we're in that premonitory state. That's
fascinating. I don't think I actually, I've read about it, but I had completely forgotten about that. So that kind of reduces those very simplistic lists that are shared on Google.
To be honest,
triggers.
Yeah, I read quite a bit. This is a fascinating thing. It's a temporal thing, right? Where you are in that temporal relationship can completely change your perspective. And we miss that. I mean, that's the beauty of science. we take. I'm not going to make this a philosophical concept, and the rounds I used to. But we overstate our ability to truly know what's happening around us.
Yeah.
And reality is, in our ability to assess data and information around it, we miss so much. And this is the perfect example of that.
Yeah.
Where we thought that it was chocolate, but it was actually our craving increased during that time, or the fact that we were more sensitive during the prodrome time.
Yeah.
That made that relationship.
So by that measure, anything could be a trigger in that phase, right? Like salty food or junk food or alcohol for that matter. All of that could be a trigger.
So what is it? What do we know as far as the true trigger? Is wine a true trigger?
Yeah, this is where it's difficult, right? So, and I read, I really got familiar with some of the literature just to make sure I was, fresh for this. And so it is difficult because we think that stress is the number one, right? People report stress being the number one trigger. And of course, there's, as we discussed earlier, there's the hormonal component. That is definitely a trigger, right? Other thing that you have to think about, we were talking about earlier about like mood changes, cognitive clouding. These are things that happen during the prodromal phase, right? So is it possible that during that prodromal phase, we're also more sensitive to stress, right? So these are, you want to get philosophical with it, right?
Yeah.
That's where it gets challenging, right? Is it just that we are more sensitive? It's a sensory disturbance disorder, right? So is it just that we're more sensitive to stress during that period of time? Is our anxiety heightened? And so we're more susceptible to stress. And is that...
And we're more aware.
And we're more aware
of stress. I mean, to be honest, your headaches, you're feeling this difference, this delta, this change in state. That change in state makes you aware of yourself. And what's the main thing that you become aware of? Stress.
Yeah.
Amazing. This is quite remarkable piece of information.
I love this very much.
Yeah.
So since we're talking about food and, and stuff, I think let's dig a little deeper. Chelsea and I used to have conversations
about food.
Food, yeah. I mean, we both love food, but we also were kind of, we have low tolerance for all the misinformation on the internet, and people say this dietary pattern is, good for prevention of migraines and headache. I want you to dive into it. Like, what do we know about the relationship between diet and headache? I'm going to say headaches instead of migraines because, I just want you to kind of tell us if there's any relationship between any different types of headaches and diet.
So I also, this also is a good segue from the last topic, because missing meals can be a trigger, right? But, again, like, you want to get philosophical with it. Like, are you missing meals because you're having anorexia related to the, premenstrual? It's very confusing. But we do have, I do have a number of patients that when they miss meals, they are more apt to get headache, again, because of homeostasis. We've talked about this. It's the brain likes to be stable. Okay. Yeah. But in terms of diet, there isn't a great deal of good research, high quality research when it comes to diet and migraine. Anecdotally, you hear a lot, right? What we do know is that caffeine withdrawal, so if you need to have consistent caffeine intake, we do have evidence for that, right? And we also have some data that MSG, could make headaches worse. But in reality, we don't have any really good literature on diets and headache control.
Right. Thank you for saying that. I know that as an indirect measure, if diet is used for, say, for example, improving blood pressure or lowering cholesterol or addressing metabolic issues, say, for example, somebody's overweight and they change their dietary pattern, they get better, their headaches get better too.
Or their sleep gets better.
Yes, that's true. I'm glad you brought that up because, for example, I brought up earlier increased intracranial pressure as a idiopathic intracranial hypertension, which is often comorbid with migraine. We do know that weight loss leads to better control of IH, and also people tend to have fewer headaches with that, right? So I'm really glad that you brought that up. And there are certain subgroups of patients that that probably do better with different dietary patterns, right? So there is a condition that I don't know if you've heard of this, called mast cell activation syndrome. Have you heard of this condition before?
Yes.
So we see a number of patients in our clinic with mast cell activation syndrome because we have 2 allergists at Keck that specialize in it. And so those patients are very sensitive to histamine. And there are foods that are higher in histamine. And so I have had patients that have, again, like there isn't a lot of data. We really need to write these things up, right? But we found that eating foods that are not eating foods with as much histamine, which unfortunately includes some very good foods, right? Like can actually help some of those patients, right? Mm-hmm. But it's really just such a selective subgroup. And so there is a lot of, misinformation out there, like, oh, the ketogenic diet is helpful for headaches. And we just don't know. We just don't know.
Talk to us a little bit about caffeine and headaches, because caffeine can actually be used as an abortive therapy for headaches at times, but it's also something that can bring on headaches. Again, it's like the complexity thing. So for people who are used to drinking coffee, if they let go of it, they get withdrawal headaches. But then in the emergency, caffeine can actually be used as an abortive therapy too, right? Talk to us about this.
Absolutely. And that's that this is true. And I've actually found that we've talked about this before at our clinic, that some patients are actually more susceptible to caffeine in increasing some of their symptomatology, right? So there is, you were asking about different kinds of migraine earlier. So there is a class of migraine called vestibular migraine. And those patients do not do very well with caffeine as compared to just a regular migraine patient. I think you have to, first of all, yes, if you're going to do caffeine, you have to do it daily. You can't just... I've had some college students that are like, well, I drink caffeine during the week and then I get headaches on the weekend. I don't understand. And you didn't have your coffee over the weekend, right? So it is confusing. But it's, I think it's important to know that for some people it's a useful treatment, and for others it can be a trigger.
Yeah. I had a patient who was I think he was either a PhD or a master's student, I forget. And he would say, whenever I go to the library, I get headaches. And it's like the 5th floor, I go there and I immediately get a headache. And when I'm at home, I'm fine. And we realized, like, this is a different aspect of it. And we realized that whenever he would go to the library during the week, he never used to wear his glasses. His glasses were for something, for something to use at home only. He would put on his glasses during the weekend, but when he was actually reading material, he would take it off. And so we realized it was his vision. Wow. And so the pattern that kind of, he kept on hating that. So he had PTSD with that library, that floor. It was actually his eyes. And, so it's so important to actually have almost like your investigation hat on to find out relationship between factors.
These little nuances of life that we have to become aware of. So talking about treatments, there are some really satisfying treatments. And I part of the is that when I saw you with your injections and for the occipital ones, though there are some really low-hanging fruits when it comes to as far as treatment of headaches, right? Some of the things as far as tension headaches. Myself, I had I wouldn't call it headaches, but I had significant pain, and some physical therapy around my neck actually completely alleviated that. But people who have occipital and some of the other ones that are easily treated, let's start with there. And then also the more advanced or treatment of migraines and what that looks like. But as far as the regular headaches that are easily treatable, what do you usually see, and what do you do about them?
So I don't get to see a lot of easily treatable headaches.
No, not at USC. No.
Not at USC. I see.
They don't help you.
Yeah. And I would love to see some easily treatable headaches. No, I love complicated patients. That's why I do what I do. But so what you're talking about with the nerve block, right? That's for occipital neuralgia, which is where you have, irritation of the occipital nerve at the base of the skull. And you can treat that. One of the diagnostic criteria is being able to treat it with what we call an occipital nerve block, where we use some lidocaine or bupivacaine, which are, numbing medications, and mix it with some steroid. Or for some people that don't want steroid, they don't have to get it. And then you target the greater occipital nerve, and for others, the lesser occipital nerve, and it should provide relief, right? Mm-hmm. And what we found is that a good portion of migraine patients also suffer from occipital neuralgia. And a good amount of people with migraine also respond well to those nerve blocks. Of course, I won't get into it too much, but insurance companies really like to deny that procedure, saying it's investigational. But it can be very useful because the occipital nerve does play a role in migraine.
Mm-hmm.
What are your thoughts about Botox? Because
I love Botox.
Yeah,
I love Botox. We have such good data on Botox, and so many of my patients, you were talking about earlier, are afraid to take medications. Don't get me wrong. I have plenty of patients that are afraid of needles. I do. But it's so great for some of my patients that can't tolerate medications, or they already have significant polypharmacy. We can do so much with Botox, and they only have to come in once every 3 months, right? So there's a good chance that they'll be able to adhere to it. The data's good. And it really can target, we have patients with headaches that develop something called allodynia, where it's like sensitivity to the skin. Mm-hmm. That is transmitted by these fibers called C fibers, C pain fibers, and Botox targets those. The data that we have says that it does target the C fibers. And it's just a great therapy. Unfortunately, most insurance companies want you to try and fail 2 of those oral medications we mentioned earlier before trying Botox.
That's right.
Yeah.
Talk to us a little bit about some of these newer medications that are out, the abortive therapies, and there are multiple different names. Some of them are injectable, some of them are oral, and they're amazing. I mean, they really work very well for a lot of patients.
They do, and I love them. They're called calcitonin gene-related peptide antagonists, and more are coming in the market. You might have heard of the latest one, zavegepant, which is going to be a nasal spray, which is very exciting, especially because we were talking about migraine-induced gastroparesis earlier. Mm-hmm. It's going to be great for those patients that can't take something orally. So in terms of prevention with the calcitonin gene-related peptide antagonists, we call them CGRP. There is a class of monoclonal antibodies. So there's 3 injectables that you can do. One targets the receptor, and 2 of which target the ligand. One of, overall, they're very well tolerated. The one that targets the receptor, arenumab, that one does have, some increased rate of constipation. Sometimes people will have increased rate of upper respiratory infections. Or if you have hypertension, they're finding that some people do have their hypertension becomes a little bit more difficult to control with that medication. But what's so nice about it with any of the monoclonal antibodies is that you have to inject it once a month and you're done.
Yeah.
Right. And one of them you can inject three times on one day, and you only have to inject once every 3 months if you find that works well for you.
Yeah.
And how effective are they?
They're very effective. It seems right now it looks like almost comparable to Botox.
Wow.
They're extremely effective.
Amazing.
Yeah. The only time I'm a little bit hesitant to prescribe those particular medications is when it's somebody that's planning on getting pregnant, because it has a really long half-life. We don't know enough yet to say this is safe, even though we have had some case reports of people that didn't want to give up their CGRP antagonist during pregnancy, and some some of what we have is that the babies are okay. For me, that's a risk I'm not really willing to take right now. So just like similar to like something like valproic acid or topiramate, I'm a little hesitant if a woman's trying to get pregnant to prescribe that medication, those medications right now. There also is a CGRP antagonist infusion that you can do once every 3 months called eptinizumab. That is we're seeing really great results with that. And then there is an oral, it's called, the oral CGRP antagonists are called gepants. And so one of them, rimegepant, can be used both as an abortive medication or for prevention. The data for that is not as good as with the injectable monoclonal antibodies, but we are finding that people are responding well to it. And then there is another oral medication that you can use for prevention called atogepant. And those, the orals, I am more comfortable prescribing a woman of childbearing age because the half-life is shorter. You can find out you're pregnant and you can just stop, right?
Exactly.
Yeah, but we are seeing really good evidence with the CGRP antagonist, and it's very exciting time in headache.
Yeah, it really is.
It is.
They didn't exist a couple of years ago, and then suddenly you have so many that works really well. What do you see in the future, right?
Yeah.
Like as far as medications are concerned?
And real quick, before we go on to that, I have to tell you that one of them, the fremonizumab, is actually also approved for cluster headache. So you just give a higher dose of it because we know that CGRP has a role in cluster headache as well.
Amazing.
Fantastic. I mean, we've evolved so much. I remember my uncle who was a surgeon who told us stories of, it's a little graphic, but before doing cardiothoracic surgery, he would have ergots inserted into the suppositories, and doing surgeries because he had to live with migraines all his life. And I remember how terrible that was.
I remember my mom's migraines. I mean, growing up, we knew when my mom would have migraines, she would lock herself up for a couple of days and we wouldn't see her because it was so bad that my dad had to actually inject her with, whatever medication back. I think it probably must have been ergots and some tranquilizers, and she would just sleep it off. It was just debilitating.
And those were powerful drugs with potential side effects. I mean, significant side effects. And now we're much more targeted and much more specific. And we have the abortive, we have the preventive. And it's quite optimistic. And like you said, it's a very exciting time for headaches and for most diseases, but especially headaches. So having said that, where do you see this going in the next few years? Yes, we're not going to bring AI and, all this world of
who knows,
machine learning.
It's affecting everything.
Discovering finding cures for everything. But before that happens, where do you see this research going forward?
Oh my gosh. It really threw me for a loop when the new intranasal spray came out, and I just thought, how come I didn't think of that? Right? I mean, it just makes perfect sense to me. They're coming out with even more devices. We didn't even touch upon the devices. I think we'll see more with that, right? And I think hopefully we have some good data coming out that using both the CGRP antagonists with Botox is very useful because they target different fibers in the peripheral system. There are some different targets that they're working on. Pituitary adenylate cyclase. They're working on that. That's another. They've seen that's another inflammatory cell that goes up in migraine that they're working as a target. And so I think there's just a lot to come. And we touched a little bit on the pathophysiology, but as I was kind of refreshing myself for our talk, there still is a lot to learn. There still is a lot to learn because there are patients that are not responding to the CGRP antagonists. And the question is why? We have data that CGRP goes up, when somebody's having a migraine. So why aren't people responding to that? And I'm hoping that maybe with more time we'll find out we can kind of piece out who will be more responsive to different therapies. And in the meantime, just trying to utilize kind of a multidisciplinary approach and targeting it from a variety of different angles is what we have right now, and probably the best thing we have right now.
And with regards to lifestyle, which is what we focus on prevention as far as lifestyle is concerned. Although there's not great data, and we want to make sure that we don't support anecdotes and things of that nature, but there's definitely indirect mechanistic phenomena. If you lower the blood pressure through lifestyle, if you lower cholesterol, if you sleep better, you reduce stress, all of these things have profound effect on prevalence, incidence, intensity of these headaches, including migraines. So lifestyle definitely has an indirect phenomenon mechanism that influences all of this.
Absolutely. And we see, so much of that at USC because we have such a strong occupational therapy program with lifestyle redesign. One of the things that they teach, which I think is so important, and we all should learn it, is pacing. Learning how to pace ourselves, taking enough breaks. We are so on the screen so much, right? Especially now, like since COVID. We were before, but now since COVID, it's been, we spend a lot of time on the screens, and learning how to manage that. We talked a little bit about post-concussive patients. They're very susceptible to different kinds of lights and different kinds of environmental input, and learning how to minimize those things. Even simple changes can make a difference, right? Sleep is very important for mood, and managing stress, right? So even though, I kind of muddied the water by saying, like, are we more susceptible because of where we are in our migraine, or is it a trigger? It doesn't mean that we can't make some changes to help manage our pain, right?
Agreed. 100%.
This has been an amazing conversation.
Yes.
Thank you so much for your time and for your expertise in a subject that is so common and so it was needed to.
Absolutely. We'll have many other conversations in the future with specific things, with something new coming up, and
I think each of these headaches could in itself be a podcast.
Oh, absolutely. The autonomic phenomenon, and all of them are so exciting. And I think, like you said, each of them can have their own topic, and it's not just about a headache.
Yeah.
It's about millions of people, like you said, 1 billion people suffering from migraines. 1 billion?
Yes, 1 billion in the world.
That's just remarkable.
That's
so
1.1 billion. I mean, you can't discount the 0.1 there. That's
that's 100 million people. Yeah. So 1.1 billion people from suffering. These are individual stories, individual times lost. And we see it in our own families. So thank you so much. I think this is so helpful for people to know what these things are, what to do about them, when there's something urgent that they need to address immediately, and the fact that there is a lot that can be done to alleviate these pains.
Absolutely. There's so much that we didn't even scratch the surface on, I was such a privilege to be here, and thank you so much for having me.
Same here.
It was ours. Thank you so much.
Thank you.